Welcome everyone to the By the Numbers 3 webinar. Thank you for joining us today. Together, the Center for Community Solutions and the Mental Health and Addiction Advocacy Coalition, also known as the MHAC, are proud to present By the Numbers 3. The Center for Community Solutions is a nonprofit, nonpartisan think tank that focuses on health, social, and economic issues. They identify community issues, analyze and explain them, and propose nonpartisan recommendations to improve health, social, and economic conditions. Established in 1913, they are a United Way agency. Community Solutions' work on this report has been made possible due to generous support from the Mount Sinai Healthcare Foundation and Interact for Health. The Mental Health and Addiction Advocacy Coalition is comprised of over 105 member organizations statewide, including health and human service agencies, the faith-based community, government and advocacy organizations, courts, major medical institutions, the corporate arena, and behavioral health agencies serving children and adults.
All attendees are muted and may unmute themselves by pressing *6.
The MHAC's mission is to foster education and awareness of mental health and addiction issues while advocating for public policies and strategies that support effective, well-funded services, systems, and supports for those in need, resulting in stronger Ohio communities. Today's presenters are John Honeck, Director of Public Policy and Advocacy, and Tara Britton, Public Policy Associate at the Center for Community Solutions, and Ed Stockhausen, Northeast Hub Director, and myself, Kelly Smith, Program and Policy Director at the Mental Health and Addiction Advocacy Coalition. By the Numbers 3 was released last Monday, July 27, and was shared widely with advocates, the General Assembly, statewide offices, the administration, each of our memberships, as well as with the media. We would like to thank all of the departments, agencies, and organizations that provided data contained in this report. The By the Numbers series all focus on developing a common understanding for the future of behavioral health care. The original By the Numbers analyzed data from state departments and those serving the community to show a comprehensive picture of the impact behavioral health disorders have across Ohio's systems and communities. By the Numbers 2 is an analysis of data from county boards on support services for individuals with mental illnesses that are not reimbursable by Medicaid. By the Numbers 3 provides an overview of Ohio's publicly funded addiction services and a snapshot of their utilization from 2007 through 2012, prior to Medicaid expansion. It focuses on the demographic characteristics of clients and treatment, the types of services they received, and spending related to alcohol and other drug addictions at the state and local levels. The most recent data in this report is from 2012, before Medicaid expansion, when a substantial number of Ohioans were uninsured and the addiction treatment system didn't have adequate resources to provide care for them. The data in this report should be used as a baseline to measure improvements in the system capacity. The Ohio Department of Mental Health and Addiction Services, the Federal Substance Abuse and Mental Health Services Administration, and the Ohio Hospital Association all were very helpful in supplying the data used in this report. In order to set the stage for By the Numbers 3, it's important to understand Ohio's need for addiction treatment. In this slide, between 2000 and 2013, drug overdose deaths increased fivefold from 411 to 2,110. If you take a look at the blue line, the all drugs category, it includes alcohol as well as substances. While the opiate crisis in Ohio has shed light on the lack of community resources available to support and treat individuals with opiate use disorders, thousands of Ohioans also need services for the use of alcohol and other substances. I'm now going to turn it over to Ed Stockhausen.
All right, thank you very much, Kelly. Thank you, everybody, for joining us today. Just to make sure that everyone is coming to this webinar from the same perspective, we want to talk a little bit as an introduction about addiction as a chronic disease. Addiction is a chronic relapsing brain disorder that is characterized by compulsive drug seeking and use, despite harmful consequences. It's categorized as a brain disease because drug abuse has caused long-lasting changes to the structure and function of the brain, notably in areas critical to judgment, decision-making, learning and memory, and behavioral control. While the initial use of a drug may be a choice, pre-existing biological, environmental, and genetic factors impact the brain's reaction to the drug. The disease model of illness has three main components. Those are having a specific physical defect, causal explanation for symptoms, and the ability to test for the disease. Addiction fits this disease model because the physical effects drugs have on the limbic system, which can be identified once addiction takes hold. And while prevention of initial drug use is one option to prevent substance use disorders, many drugs have legitimate medical purposes and cannot be entirely avoided. We'd like to review quickly some aspects of successful treatment and support. Treatment must include both behavioral choice changes and medical intervention. Alterations in the brain make self-control, decision-making, and long-term planning much more difficult, and research has shown that patients with substance abuse disorders experience difficulties in treatment at the same rate as individuals with other chronic diseases. Each individual must receive treatment tailored to their special needs in order for it to be effective. The stages of treatment include detoxification, assessment, long-term treatment, and crisis intervention. And the three categories of long-term treatment services are both clinical and non-clinical. They are behavioral therapies, medication, and supportive services, broken out as you see in front of you there. The Department of Mental Health and Addiction Services categorizes treatment under various levels of care, and those levels before you describe the type, intensity, and location of treatment. So that's a breakout of it. And the Federal Drug Enforcement Agency categorizes controlled substances into 5 categories based on medical use, potential for abuse, and safety and dependence liability. You have some examples there of different drugs classified from Schedule 1 with the highest severity all the way down to Schedule 5 to cough medicines. Now, as far as the scope of addictions is concerned, we know that addiction disorders affect a wide array of other systems that are used by people. This includes the criminal justice system, where in 2014 alone, there were over 5,000 drug-related felonies in Ohio. And in fact, because it's such a widespread problem, we have 92 drug and family dependency courts in Ohio operating as of March 2015. The child welfare system, over 320,000 Ohio children live with at least one parent with a substance use disorder. We know that this means there's an extra $45 million in foster care due to parents' heroin and opiate use. And as far as the workforce is concerned, 450,000 illicit drug users are employed in Ohio. That's full and part-time. Nationally, $193 billion. It costs the national economy $193 billion from illicit drug use alone, and the use of alcohol costs $235 billion. I'm going to turn it over to Tara at the Center for Community Solutions to continue talking about the scope of addiction.
Thanks, Ed, for that great overview. I'm Tara Britton with the Center for Community Solutions, and I will begin by sort of adding to the background information here and looking at the scope of addiction. To understand the scope of substance use disorders, it's important to know how many people are using and are dependent on these substances. The National Survey on Drug Use and Health, or NSDUH, conducted by the Substance Abuse and Mental Health Services Administration, or SAMHSA, we like our acronyms, collects data through face-to-face interviews with a representative sample of the population at the respondent's place of residence. So this is how the data for NSDUH is developed. The percentage of adults 18 and older who are dependent or abusing illicit drugs in Ohio is displayed here in orange, and this rate is slightly higher than the national and Midwest rate. The Midwest region is determined by NSDUH and is comprised of 12 states. Those are listed out in the full report. Numbers-wise, about 238,000 Ohio adults were dependent on or abused an illicit drug based on this 2011 and 2012 survey data. And this is including marijuana in that illicit drug category. If you look at sort of a different measure that NSDA gathers data on, it tells us that 301,000 adult Ohioans, or about 3.5% of adults age 18 and over, have used an illicit drug other than marijuana within the past month. So this is looking at a different time period, but sort of gives you information based on dependent or abusing versus use within the past month. So there's much more detail on these types of measures in the report, but this is sort of setting the stage on the illicit drug use or abuse and dependence. And then moving on, we'll look at the scope of addiction in terms of dependence or abuse of alcohol. This is also using NSDA data. In 2011 and 2012, there were 629,000 adult Ohioans, or 7.2% of adults age 18 and older were dependent on or abusing alcohol. And this is a little bit lower in Ohio in the orange compared to the Midwest rate, which is in blue, but a little bit more comparable to the national rate. So getting into looking at the need for treatment, there's one component of our report where we look at, again, using NSDA data from 2011 and 2012, but it shows that overall, less than 10% of people abusing or dependent on drugs are receiving treatment. And this number it's just over 5% of people abusing or dependent on alcohol are receiving treatment. And so it's a very small percentage of the people who are using or abusing or dependent on these substances that are actually receiving treatment. And then looking at the table in front of you, this is the estimated number of people needing but not receiving treatment for alcohol and illicit drug use. And this is a 3-year average rate. We calculated out these rates using census data as well. So this is not a number that appears verbatim in the NSDA data, but we use NSDA and census data to develop these figures. So in Ohio, these numbers come out to, for alcohol use in the past year, people needing but not receiving treatment was a little over 638,000. On the needing but not receiving treatment for illicit drug use in the past year, this number was a little over 250,000. So we have the percentages there so that you can compare them across Midwest and nationwide too. But on the illicit drug side, Ohio is a little bit higher percentage-wise, but in alcohol use, needing but not receiving treatment, Ohio is a little closer to the nationwide and Midwest rates. In the report, we have this information available for different counties and regions that were determined by NSDA. So it's not data available for each individual county necessarily, but they are for different NSDA survey regions. And these numbers are, again, available in percentages and numbers of people needing but not receiving treatment. Just one quick note on, as we were putting together this report, this is actually one, unfortunately, a location where we found an error, so the actual number of people needing but not receiving treatment for illicit drug use was incorrect in the initial printed version of the report, but we've since corrected this on the electronic version. So if you were really excited and downloaded it on that first day, I would suggest going back and re-downloading it so that that number has been corrected. Moving on to some data that we crunched the numbers on that came from the Ohio Hospital Association, and again using U.S. Census Bureau data. These tables summarize the counties with the highest and lowest per capita emergency room visits and hospital admissions with primary and secondary alcohol and drug diagnoses. This excludes nicotine, and we used basically diagnosis codes that were related to alcohol and drug use. So smaller counties in general tended to have lower per capita visits than larger counties. This data tracks admissions and visits instead of people, so it's not a measure of incidence or prevalence, but offers a measure into how often hospitals are utilized in a community to treat substance use-related issues. That essentially means that an individual could have multiple admissions. The same person could also have an ER visit as well as an admission within a year, although I will point out that ER visits that result in an admission are only counted as admissions. So if you come in through the emergency room and you're admitted, that counts as an admission, not an ER visit. We also, just so for your reference, the appendix of the full report includes a list of all the counties in the state containing this same information. So if you'll look on the left-hand side of your screen, these are the counties that have the highest number of hospital admissions and ER visits with any AOD-related diagnosis. Hamilton County and Cuyahoga at the top. You do see one smaller county, Wayne County, over there on the highest per capita visit side, and then over on the right-hand side are the counties that have the lower visits as a percentage of population. And really what we took from this data was that it's a good barometer, something to monitor about what's going on in a community and how often its citizens are showing up in hospitals with substance use related diagnoses. This is something that we'll come back to in the conclusions of our presentation, because we think this is something that really tells us something about what's going on in the community. Moving on, this is sort of we just wanted to put this information out up front, key points on data analysis. So as Kelly mentioned, this data does not show the impact of the expansion of Medicaid. I'm mentioning this now because the next slides will go into funding information, and that's something to keep in mind, that we're not looking at data that is impacted by Medicaid expansion. I also want to mention, as we move into discussing more of the treatment-related data in a few slides from now, data from the Ohio Behavioral Health Survey and the Multi-Agency Community Services Information System, which is OHBH and MHAC. They are presented in 2-year periods. This is to protect client confidentiality. Combining 2 years' worth of data ensures that client confidentiality is maintained, at the same time reduces data suppression, so that the data that we're presenting you can really be analyzed and compared to other years. So I just wanted to state that up front so that folks know sort of our not necessarily our limitations, but just sort of what data we went into this report with. So moving into a quick discussion of funding. So we did use the financial reports that alcohol, drug addiction, and mental health boards report to the state agency. So this is a breakout of funding for fiscal year 2011. Again, this is pre-Medicaid expansion, also pre-Medicaid elevation. So we're really sort of looking at all of the dollars that are flowing through the ADAM board. This figure includes both state and federal Medicaid funding. As you all know, Medicaid is a very important source of funding for addiction services, as well as funds from local levies. Local levies provide resources for addiction services, although not every county has a local levy. In this figure, the primary sources of state funding for addiction services, and this is, again, on the state funding side, came from the General Revenue Fund and the State Special Revenue Fund. This financial data matches up with the years of the treatment data that we analyzed. So now that the Medicaid match has been elevated to the state, this will look different, obviously, in future years, current and future years, but for consistency's sake, we matched the funding data up with the most complete and available treatment data that we had. One more slide on funding. So this sort of takes a deeper dive into the types of services that ADAM boards are funding. So this is a statewide snapshot of addiction spending in Ohio, and this is fiscal year 2012. But the level of spending on these services varies individually by board. In 2012, boards in Ohio spent the majority of all sources of funding on treatment services. You'll see that there was 66% going to treatment services, at $162 million. Total spending reported by boards for fiscal year 2012 was $245.7 million. This includes federal, state, and local sources. Treatment services, as you can see here, are by far the largest area of spending. This is followed by housing, board administrative and other services, prevention services, and community and adjunctive services. The housing, I will note that the housing category includes both hospital and non-hospital-based community residential treatment services, as well as room and board. Room and board was counted in the adjunctive services category, but we sort of broke this out so that we could get a clearer picture of housing services. So next we'll move into the details on treatment, and I will turn this portion over to John Honeck. And this data ranges from demographics to primary drug for which to be in treatment, as well as medication-assisted treatment. So I will turn the presentation now over to my colleague, John Honeck.
Thank you, Tara. So it's my job to walk everybody through some of the client information that we have for the report. First, let me talk about the Ohio Behavioral Health Survey, or OHBH. So this is based on a survey that providers fill out for each client at admission. For our study, the board-level data was provided through OHBH, while statewide totals were from MHAC. And let me acknowledge some of the limitations of the OHBH data set. So the OHBH system was able to track at the board level nearly 120,000 clients receiving substance abuse treatment through the public system in 2011 and 2012, which was far less than the 160,000 identified statewide by MHAC. In each of the three biennia analyzed for the report, MHAC figures were higher than OHBH. And neither source includes the number of people in Ohio receiving services through private insurance or self-pay. Now, looking more closely at gender, one of our goals was to create an accurate picture of the demographic characteristics of the population receiving treatment. Looking at gender, despite the large fluctuations of the total number of clients served, the demographics of the clients have stayed very stable. Men made up over 60% of the clients statewide across all three biennia. Over the period of time included in the study, all but 2 board areas treated more men than women. And looking at the breakdown of clients by age group, there was a similar kind of stability. The 26 to 44 age group made up about 45% of all clients. About 10% of clients were age 17 and under. A quarter of clients were age 18 to 25, and another 20% were between ages 45 and 64. And very, very few clients were age 65 and older. And one of the most important data points that we asked the department for was clients' primary drug of choice. About 40% of clients in 2007-08 were being treated for alcohol. This decreased to 35% of clients by 2011-2012. Marijuana was the primary drug of choice for nearly 25% of people in treatment in 2011 and 2012. And heroin and other opiates together made up about 1/4 of the people in treatment. The percentage of clients in treatment for marijuana, heroin, and other opiates increased steadily over the 3 biennia. Alcohol and cocaine saw decreases. Still, in 2012, alcohol remained the single most common drug for which to be in treatment. More recently released data for FY 2013, which we did not have time to include in the report, showed that opioids, meaning heroin and other opiates combined, have surpassed alcohol as the primary drug of choice for which people are in treatment in Ohio, and this demonstrates the growing problem of opioid abuse. This map shows for each board area the most common primary drug of choice for which to be in treatment in 2011-2012. Given the prevalence of alcohol and marijuana use statewide, it was not surprising that alcohol was the most frequently treated substance in 34 board areas, and it was the second most frequent in 8 others. 11 board areas had clients with heroin and other opiates as the most frequently treated substance. Boards with this characteristic had a distinctive regional pattern and were located in the southern or eastern parts of the state. These board areas are highlighted in the purple or magenta color in the map. The map does not show the board areas that had opioids as a second most frequent client drug of choice. These areas were more widely dispersed geographically and included Franklin County, one of the largest urban areas in the state. The choice and availability of levels of care to treat addiction varies by drug. OHBH categorizes treatment into 9 categories during the 2011-2012 biennium. These levels of care are fully defined in the report. In 2011-2012, outpatient treatment made up the vast majority of drug treatment services in the state. The largest percentage of clients are in the non-intensive outpatient level of care, about 63%. More than half of all clients were in this level of care in every drug category except for heroin. Intensive outpatient treatment made up another 13%. Pre-treatment made up 11%, and 6% were treated in non-medical community residential settings. In terms of the trends in the utilization of levels of treatment, non-intensive outpatient treatment dropped from 78% of clients in 2007-08 to 63% in 2011-2012, while the use of other levels of care increased. Pre-treatment grew from 4% to 11% of clients, and intensive outpatient and non-medical community residential treatment also saw increases in the percentage of clients. And there's a lot going on in this particular slide, so I really urge you to look at the report. But the figure shows the number of boards utilizing specific levels of care for each drug. At the county board level, not every level of care is utilized to treat every drug. Again, the only near universal level of care used to treat any given drug type was intensive outpatient treatment. Day treatment, medical, community, residential, and all 3 types of detoxification were each utilized by fewer than 20 of the 50 boards for any drug type in 2011-2012. We also want to note that the data does not address whether a level of care that a client needs is necessarily the level of care that he or she is receiving. A related data set that we utilize for the report is the Treatment Episode Data Set, also called TEDS, which is coordinated by SAMHSA. TEDS reflects survey information for people in treatment at admission and discharge. It's based on the OHBH data set, but provides a duplicated count of clients who are admitted and discharged in a year. While it's required that a treatment facility that receives any public reimbursement submit this data to the state for all clients, we know that compliance is not universal, especially at discharge. Still, this is the data that the state submits to the federal government as representative of treatment episodes within facilities that provide publicly funded services. In addition to an outcome where people complete their treatment, clients are discharged for other reasons. These can include that they left against professional advice, that they had their participation ended by the facility, that they were transferred to other levels of care. It might include carceration, it might include death, and there might be other reasons, including moving or hospitalization, or certain reasons outside the client's control. The report contains this breakdown for each primary drug of choice. What I'd like you to note is that depending on the drug of choice, there were significant differences in the percentages of clients completing treatment. For alcohol, 44% completed treatment, but for heroin, 22% completed. Other drugs were in between, with an average of 36% across all primary drug of choice. And note that this comparison is across levels of care as well. The second table, the service setting at discharge, long-term residential rehabilitation and non-intensive outpatient treatment had the highest rates of clients successfully completing treatment. Detoxification levels of care recorded the lowest percentages of clients successfully completing their treatment, but as you would expect, the highest percentages of clients transferred to other levels of care. The report includes tables for discharge by service setting for 3 major drug types: alcohol, marijuana, and heroin combined with other opiates. One of the most important issues facing the addiction treatment system today is the use of medication-assisted treatment, or MAT. MAT is defined as the use of medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance abuse disorders. MAT provides a safe, controlled level of medication to reduce problem addiction behavior. It's considered the standard of care for opioid use disorder. The data in the report show that the use of MAT has become more widespread over time. More board areas are utilizing MAT. In 2007-08, 14 boards did not have any clients treated with MAT. By 2011-2012, this number shrank to 4 board areas. MAT is not utilized evenly throughout the state, however. In 2011-2012, there were 17 boards that provided MAT to 25 or more clients, which together accounted for 95% of all the instances of MAT. Those same boards saw 67% of all clients with an opiate diagnosis. This table shows the number of clients receiving MAT statewide. While the total number of clients receiving MAT for heroin and opiate use increased every year, the increase in the total number of clients seeking treatment and in treatment for opioid use meant that MAT was reaching a lower percentage of potential clients. In other words, the use of MAT was not keeping pace with demand. So now I'll turn the presentation back over to Kelly.
As we move into the future, it will be important to continue to monitor and evaluate the addiction treatment system and how well it's reaching people. The ACA, namely the expansion of Medicaid, will continue to impact the clients and services described in this report. Limitations of this analysis, given that the data is before 2014, include the absence of Medicaid expansion for this population and the substance abuse services they are receiving. We are beginning to see this data, but it will take time to reveal the full effect Medicaid expansion has made and what still needs exist. The publicly funded treatment system is already beginning to see shifts in the types of services it is providing and the population it's serving. The information gathered and analyzed as a result of this report offer a baseline against which to measure change over the coming years. Certain questions remain, and additional information would help in understanding these changes. And Tara Britton is going to finish the last conclusion slide.
Thanks, Kelly. So these concluding remarks, and again, we encourage you to refer to the report as we expand upon these conclusions. These really stem from the data we were using and sort of the current environment of what's going on in the state. So to start, there's a need for better reporting of data, both on the number of clients and outcomes. So while there's sort of vast amounts of data available, it is lacking in regards to measuring the factors that lead to treatment completion and offering a complete picture of clients being treated. An important component of this as well is to develop an effective measurement for unmet need. And I think something to keep in mind as we go through these conclusions is that we are looking at the publicly funded treatment system and data, so we're not looking at private insurance and self-pay clients, which also is a big part of the addiction treatment system in the state. And I think the first step in looking at all of this data together is evaluating both publicly and privately funded treatment services to offer this more complete picture. This would get us closer to being able to directly compare data on unmet need to the number of people receiving services and those that still need to be receiving treatment. Looking at the utilization of medication-assisted treatment is another important point. John certainly touched on the data that is available, but in light of the continuing crisis with opioids, both prescription and heroin, it is important to have an understanding of the extent to which MAT is being utilized. And I'm realizing I skipped over the third bullet, but going back to that one, looking at how collecting better state-level data on the effect that substance abuse has on Ohio's workforce is something that would be important to know, especially when developing policies. Currently, this data is only available at the national level, so the information that we included in the report is basically taking the national level figures and sort of applying them to Ohio, but we would want more complete data that is Ohio specific. And moving on to choices around level of care and availability of providers, we want to make sure that everyone is receiving the treatment that is most appropriate for their needs, and we wouldn't want information or treatment to only be available to people based on funding or just the providers that are available. We want them to be able to receive treatment that most meets their needs. Collecting hospital data on visits and admissions relating to substance abuse. So I mentioned we would get back to this when we got to the concluding section. Hospital data on visits and admissions related to substance abuse can be a very helpful barometer of the need for substance abuse treatment. Combined with data on overdoses, this information would establish a baseline to understand and compare substance abuse trends. So this is certainly something that we would want to continue to monitor. Looking at the overall impact of the Affordable Care Act on ADAM boards and their finances. So as Kelly mentioned, we want to keep monitoring what the impact of the Affordable Care Act Medicaid expansion, as well as expansion of private insurance through the marketplace, will have on ADAM board finances, as well as how people are being treated and where they're receiving treatment. And it will be important to know in the future whether boards will shift to paying primarily for more supportive services, which in By the Numbers 2, we laid out how important these services really are in completing that continuum of care for folks in recovery. Research should also be conducted to determine which populations are left uncovered after the Affordable Care Act is more fully implemented, and how Ohio's safety net will continue to provide some substance use treatment for individuals that do not have a payer for services. And then sort of more data specific. So Medicaid elevation created the need for providers to report data in several different data systems. This has been provider adherence to reporting protocols in these sort of different systems has really been affected by Medicaid elevation and sort of adds to the places where data needs to be reported. And I think the existence of multiple data systems has made it more difficult to track funding and the needs of people living with substance use issues. So as we're still in a transition period, we'll hope that being able to get fuller information on client service delivery and outcomes will become more transparent, standardized, and more reliable as we move forward. So I am going to turn it over to Ed to sort of moderate any questions that we've received, and folks we welcome any questions that can be submitted through the chat box feature.
All right, thank you so much, Tara. So for anyone who has any questions, please feel free to either send them and make them available for everyone to see, or you can send them directly to me. Again, it's Ed Stockhausen. You can send those directly to me if you have any questions. Let's give it a moment to see if anyone's got something that they need to type up and send this way. Actually, if John and Tara, we got one question that was asking you, if you guys could provide a little bit more information about the sources of your data, especially some of the statewide data related to the number of people receiving treatment through the publicly funded system.
Yeah, Ed, so there are several main sources. One was MHAC and one was the OHBH, and those were both provided to us by the department. One really was looking at is a provider created data at admissions and discharge. and MHAC was more of a sort of on the billing side of the house, if you will, on the financial side. And so in terms of the overall client count, the MHAC number was a little bit more complete and a little bit higher, but didn't necessarily have the kind of client demographics that we're looking for certain parts of the report.
Great, thank you. And there's actually a question about missing data. One of the figures in the report showed that there were 4 counties for which primary drug of choice data was not available. Is that because it's not being reported, or for some other reason about protecting persons' information or identities?
Ed, this is John again. We had both situations, and I'd have to go back and look at, depending on the particular charter figure. There are certain situations where if the client count was 25 or less, then those data were suppressed to protect confidentiality. We also had a few situations where the information simply wasn't being provided. And so we did have both situations occur.
Great. See, for the folk who aren't on the computer, we've got one individual who just wanted to let us know that we need to pay close attention to the impact of carving behavioral health benefit back into Medicaid managed care. Thank you for that comment. And another question that just came in is one of the major challenges of those working with survivors of human trafficking who are also victims of substance abuse is availability of detox facilities. Can you comment on where detox care can be accessed and how to reach such resources in a timely manner?
This is Tara, and thanks for the question. We did not look at specific availability of any services. This was sort of a retrospective of what services folks had received. So unfortunately, can't answer that question specifically, but I'm sure there's many resources, I'm sure, available through the local ADAM boards, the department, and providers in different areas.
Great, thank you.
And this is Tara again. I guess I will also comment on the comment that we received about paying specific attention to carving in the behavioral health benefit package. I know that's something that all of us, both at the Center for Community Solutions and the Mental Health and Addiction Advocacy Coalition, are paying very close attention to, and certainly is one of those things that factors into our concluding statement about monitoring the availability of treatment services into the future and sort of checking back in on some of these data points as we see how the Affordable Care Act, as well as carving in the behavioral health benefit package into managed care, certainly impacts what we'll be looking at in the future.
Much, Sarah. If anyone else has any other questions, please feel free to send those on over. We did receive one question here. If Tara, Don, or Kelly has some additional information for us on the issue of medically assisted treatment. Was that limited to methadone, or was that more inclusive?
Ed, this is John again. That would be, especially going back to 07, 08, that would be mostly methadone.
And this is Tara. I will add, though, that when we talk about medication-assisted treatment in this context, we are talking about that sort of full package of services and not just sort of that prescription by itself. So it's not just looking at the actual prescription that goes into that. It's the follow-up services, the counseling, all of that goes together.
Great. Thank you guys for providing an answer for that one. I don't have any other questions just yet. If anyone has anything, please feel free to send it on over. Give us another second or two here.
And this is Tara. I will add that, we're happy to take any questions via email as well. So you can visit any of our websites and get our contact information. You can see contact information for two of us up on your screen right now, but you can reformat those email addresses with first initial, last name if you have specific questions for anyone else. We're happy to take follow-up questions, especially as folks delve further into the report. It's not a quick read, but a worthy one.
And we really appreciate the fact that in our chat box, you guys have provided a link to download the presentation. So anyone who hasn't done that, feel free to go ahead and click that. It came from the CCS administrator.
I think if we don't have any further questions now, we can probably wrap everything up, and like I said, we're happy to take any questions or feedback later on.
Wonderful. Well, thank you to everybody who was able to join us today. Really appreciate your interest in By the Numbers 3. And like Tara said, we are more than happy to answer any additional questions that might come to mind as you guys continue reviewing that report. And with that, I just want to let everyone know I did get one last email, and we will make sure to have that report available if you weren't able to download it yourself for any technical issues. Feel free to reach out. But thank you, everybody, for your time today.